Dear students, good evening and assalamu alaikum. Today our topic is organophosphorus poisoning, and you know this is a common poisoning in the daily practice. Even in the medical college admission, it is very common. So organophosphorus compounds are chemical agents, and which is widespread use throughout the world, mainly in the agriculture. It actually used as pesticides, and they are also used as nerve agent in chemical warfare, that is the sarin gas, and as therapeutic agent in the treatment of glaucoma. They comprise the esters, amides, or thiol derivatives of the phosphoric acid and are most commonly used in pesticides in commercial agriculture, field spray, and as household chemicals. So this is main use is in the paddy field, agriculture, and the common poisoning we have seen in the rural people, those who are working in the paddy fields. So this is also common poisoning. Now the classification. There are more than 100 organophosphorus compounds in common use. These are classified according to the toxicity and clinical use. Highly toxic organophosphates, that is tetraethyl pyrophosphate, that is parathion. These are mainly used as agricultural insecticides. And second one is intermediately toxic organophosphates, for example, that is trichlorophon or chlorpyrifos. These are used as animal insecticides. And low toxicity, that is diazinon, malathion, these are used household application and field spray. So you will see how it is how the exposure occurs. In the home exposure, that is the accidental ingestion, and occupational exposures, farms and farm worker, other exposure, dietary exposure, pesticides, residues on the crops. And in the home exposure, that is the lawn and garden use, that is pesticide applicator, leaching from the soils to the groundwater. For insect control in the field of manufacture, that is community exposure. Food supply, mixing and handling, airborne drift from commercial application. Water supply, that is the landscapers, that is the contaminated drinking water. So these are the ways how these insecticides actually come to play in the field of poisoning. So it may be in the agriculture field or even in the household use, or they may be also accidentally taken, or they may be also in the intention of suicidal poisoning. Absorption route, you know, that is cutaneous absorption, ingestion accidental or suicidal if they ingest the poison, inhalation and injection. So these are the routes of absorption of this poisoning. Now comes to the pharmacokinetics. Most organophosphates are highly lipid soluble compounds and are well absorbed from the intact skin, oral mucous membrane, conjunctiva, and gastrointestinal and respiratory tract. They are rapidly redistributed to all the body tissues. The highest concentration are found in the liver and kidneys. These high lipid solubility means that they easily cross the blood-brain barrier and therefore produce potent effects on CNS, central nervous system. Because of high lipid solubility of these compounds, metabolism occurs principally by oxidation in the liver with conjugation and esterase hydrolysis, producing a half-life of minutes to hours. So main metabolism occurs in the liver by esterases, and which is hydrolysis producing the half-life of minutes to hours, then it excretes. The oxidative metabolites of malathion and parathion are active forms and are subsequently hydrolyzed into inactive metabolites in the liver. Elimination of organophosphorus compounds and its metabolites occurs mainly in the urine, bile, and feces. So, these are the way how the inactive compounds as well as the active compounds actually excretes by the urine, bile, and feces. So, this pathophysiology is important to understand the symptomatology of this organophosphorus poisoning. You know, the nervous system is made up of a large number of nerves. When a signal reaches the end of the nerve, it releases a substance called neurotransmitter that carries the signal to the adjacent nerves or organ such as muscle or gland, and many nerves release acetylcholine as the neurotransmitter. Once the signal passes to the next nerve, an enzyme called the cholinesterase which destroys this acetylcholine. So this is very important. This is cholinesterase. Otherwise, if there is a prolonged action of acetylcholine, it will produce many symptoms. And this poison actually neutralizes or they bind these cholinesterases. So the half-life of acetylcholine is increased. So organophosphorus compounds block this enzyme, thus preventing the breakdown of acetylcholine. Then acetylcholine acts for an excessively long time, like twitches and increased secretions. Then there are many effects. We will subsequently talk about that. That is muscarinic effects, nicotinic effects, CNS effects. After some time, the muscle gets fatigued, leading to paralysis. So this is in a nutshell of pathophysiology of these compounds, of this poisoning. Following exposure to organophosphorus compounds, the toxic features usually obvious within 30 minutes to 3 hours. This may be delayed in some cases, depends on the rate and amount of systemic absorption. The clinical symptoms and signs are non-specific and will depend on the specific agents, the quantity and the route of entry. Some patient presents with vomiting, diarrhea and abdominal pain, while others may be unconscious on arrival at hospital. A high index of suspicion is therefore needed to make the early diagnosis. The clinical features can be broadly classified as secondary to the muscarinic effect, nicotinic effect, and CNS stimulation. So, a patient may come to you with unconsciousness, or he or she may present with vomiting, diarrhea, abdominal pain, and some smell. You can suspect. If you take proper history from the attendant, then you will get the history that he or she may take some substances, and the features are like that. Then you will suspect probably this is a case of organophosphorus poisoning. Now comes to the clinical features. Acute organophosphorus poisoning, there may be intermediate syndrome, delayed neuropathy, and neuropsychiatric disorder can occur. In acute OP poisoning, there may be muscarinic features, there may be nicotinic features, there may be CNS features can occur. And ultimately, there is respiratory distress and death can occur. Now come to the symptomatology. That is the muscarinic effects, nicotinic effects, and CNS effects. In muscarinic effects, in case of cardiovascular system, you may get bradycardia and hypertension. But say if there is a nicotinic features is predominant, you may get reverse. That is, a patient may present with tachycardia or hypertension. In respiratory features of muscarinic effects are rhinorrhea, bronchuria, bronchospasm, and cough. So, if you auscultate the lung, you will get a spasm, and there is also some crepitation due to increased secretion. All secretion will be increased. In case of GI features, you can get nausea, vomiting, increased salivation, abdominal cramps, diarrhea, even there may be fecal incontinence. Increased GI motility can occur due to this muscarinic effect. There may be genitourinary effect that results in urinary continence, involuntary passage of urine. And in eyes, there may be blurred visions, increased lacrimation and miosis. That is, pupil will be constricted. And when you will give atropine, and when there is a features of atropinization, that is the pupil will be dilated. In glands, you will get excessive salivation. So these are the features of muscarinic features of this poisoning, that is organophosphorus poisoning. These features are actually predominating features. In case of nicotinic features, you will get in cardiovascular system tachycardia, hypertension. In musculoskeletal system, you will get weakness, fasciculation, cramps, and paralysis. In case of CNS features, that is general effect, you can get anxiety, restlessness, ataxia, convulsion, insomnia, dysarthria, tremor, coma, absent reflexes, respiratory depression, and circulatory collapse. Among these, patient may come to you with features of coma, and patient may become very much restless. There may be some attraction and convulsion can occur. And ultimately, there may be some respiratory depression as well as the circulatory collapse can occur due to this CNS effect. Now comes to the neurological manifestation. 3 different types of paralysis are recognized based largely on the time of occurrence and their different pathophysiology. That is, type 1 paralysis, acute paralysis can occur. Type 2 paralysis or intermediate syndrome can occur. There may be a short note on intermediate syndrome. And type 3 paralysis or organophosphate induced delayed polyneuropathy can occur. So these features you can get actually in course of time. So say the organophosphate induced delayed polyneuropathy can occur even weeks or months later can occur. Now comes to the management. Actually, diagnosis of organophosphorus poisoning based on the history of exposure to organophosphate compounds, characteristic manifestation of toxicity, and improvement of sign symptoms after administration after administration of atropine. So high degree of suspicion is very important. Say a patient came to you in a features of say unconsciousness, and there is excessive salivation, and on examination you are seeing there is a miosis, and there is a lung finding, there is also abdominal findings and other features. So high features, a high degree of suspicion is important for the diagnosis. There may be some smell, garlic-like smell can occur. Is an added clinical sign, especially if the patient has ingested sulfur-containing organophosphorus compound. Garlic-like smell can occur. This may be aided by insisting the patient attendant to search for a possible poisoning container in the vicinity of the patient. If attendant take the container that contains the organophosphates, you can be sure that this may be due to organophosphate poisoning. Now comes to the investigations. Routine blood test, complete blood count, ECG, you can get some changes. In chest X-ray, if there is some opacities can occur, and there is a marked depressed serum pseudocholinesterase activity below the normal rate. If there is facilities of measuring the pseudocholinesterase enzyme, you can measure it. Arterial blood gases, there may be acidosis, pH will be low, and also bicarbonate will be also low. Serum electrolytes and serum creatinine in response to respiratory distress and shock and within 1 to 6 hours. So and this is a mainly clinical diagnosis. Lab investigation can give you some help. Cholinesterase estimation, if facilities is available, are the only useful biochemical tool for confirming the exposure to organophosphate compounds. So if facilities is available, it is a cholinesterase enzyme that will be helped. Though the enzyme activity does not correlate well with the clinical severity. Now comes to the main treatment portion. Actually, decontamination is important. You have to you have to remove all the clothes from the body, and you have to give the washes to the the hairs, and you have to clean all the contaminant from the surface of the body, and you have to block the muscarinic activity with atropine. So atropine is a very important modality of treatment, and as I have already told you, that is inhibition is a marked feature. So reversal of cholinesterase enzyme with OXIMES. So you can give if patient comes early. And correction of metabolic abnormalities. If there is a metabolic acidosis, you will correct it. And prevention of infection and management of complications. So these are the headlines by which you will manage this patient. Decontamination is important, supportive therapy is important, and then specific drugs like atropine, prelidoxime. You will correct the metabolic abnormalities, you will prevent the infection, and as well as you will manage all the complications. Now, decontamination and supportive therapy. Comatose or vomiting patients should be kept in left lateral, preferably head down position with neck extension to reduce the risk of aspiration. Risk of aspiration is there if not position is not maintained. So lateral position is very important. Patient airway should be secured with the placement of airway or with endotracheal intubation, especially if the patient is unconscious or having seizure. So airway should be clean, and if needed, endotracheal intubation can be given. Frequent suction is essential as excessive oropharyngeal and respiratory secretion may occlude the airway, because all secretion will be increased by the muscarinic effect of organophosphates. So frequent suction you can give. Need for oxygen therapy can be assessed by frequent assessment of arterial oxygen saturation. So by pulse oximetry, you can see whether oxygen saturation is decreasing. Say in normal people, if say below the 92, normally normal range more than say 96%. So if there is it less than 93 to 92%, you must give the oxygen, like in the COVID patients. Now comes to the main drug, that is the atropine. It is anticholinergic drugs because there is excess accumulation of acetylcholine. As we have seen, that is acetylcholine enzyme is blocked and acetylcholine level is increased. So the drug will be anticholinergic drug, that is the atropine. What is the objective? To block the muscarinic receptor until the organophosphate is metabolized away from the body. What about the dose? Adult dose is 2 to 5 milligram IV, repeated every 5 minutes, doubling the initial dose. If not responding, if there is no sign of atropinization, it will double the dose of initial doses. In case of children, it will be 0.05 to 0.1 milligram per kg, given till signs of atropinization occurs. What are the signs? That is, pupil will be dilated, there will be secretion will be diminished, and other features you will get it. Temperature will also be raised. So by this you will gauge there is a features of atropinization. Continued treatment, maintenance dose is about 30% of atropinization dose for 1 to 2 weeks. So atropine is the main drug in this organophosphate poisoning. But you have to look for any side effect or toxicity of atropine. What are those? Agitation, confusion, hyperthermia, urinary retention. Retention is also a feature of atropinization or toxicity, and severe tachycardia. So if you block the muscarinic effect, nicotinic effect will get upper hand, and there will be also the tachycardia. Can precipitate ischemic events in patients with underlying coronary artery disease. If there is a tachycardia, so the oxygen demand of the heart tissue increases. If there is a jeopardy, if supply not adequate, so ischemic episodes can occur here. Over-atropinization may necessitate this, discontinuation of the atropine infusion, followed by frequent observation. When they settle down, the infusion is to be started at 70 to 80% of the previous rate. Anticholinergic agent glycopyrrolate along with atropine can be used in order to limit the central stimulation produced by atropine. So when you are repeatedly giving the atropine, you must look for the toxicity, and these are the features. If you get, then you have to reduce the dose of atropine, or even you have to stop if there is any atropine toxicity. Now comes to the gastric lavage should be considered in patient presenting within 1 to 2 hours of ingestion of poisoning. But if there is a more time, then actually lavage will not be helpful, because by this time poison will be absorbed and there is a systemic features. Risks of gastric lavage can be, there is maybe aspiration in the lungs, hypoxia and laryngeal spasm can occur, and reduced with proper management of airway. If you properly manage the airway, there is a less chance of aspiration. Activated charcoal can be given to reduce the poison load by absorbing it. Its efficacy has not been conclusively proven in human. Single to multiple dose of activated charcoal is routinely used in clinical practice. Avoid cathartics and induced emesis, because if you induce emesis, there may be a chance of aspiration. Charcoal previously it was practiced, but nowadays it other things. Gastric lavage can be given if comes within a very short time. Now comes to the reversal of cholinesterase inhibition by OXIMES. OXIMES work by reactivating the acetylcholinesterase enzyme that has been bound to the organophosphate molecule. And most commonly used drugs is pralidoxin, and it is a nucleophilic agent. Mechanism of action: oxime get attached to the free anionic site of the enzyme cholinesterase. The oxime end then reacts with the phosphorus atom of organophosphate attached at the steric site of the enzyme. The oxime phosphate so formed diffuses away, leaving the enzyme intact. So actually it reactivates the enzyme cholinesterase. By this way, it actually inactivates all this poison. So dose, WHO recommend pralidoxim dose of 30 milligram per kg bolus over a period of 20 to 30 minutes, followed by continuous infusion of 8 milligram per kg per hour infusion, continued till recovery. 12 hours after atropine has been stopped, and acetylcholine enzyme noted to be increased if possible, if you can measure. Largest oxime trial recommends 2 gram loading dose followed by 500 milligram hourly, maximum actually 7 days, not more than this. Side effect: there are many side effects. Dizziness, headache, blurred vision and diplopia can occur. And formation of stable phosphoryl oxime, high on anticholinesterase activity. Rapid administration may lead to tachycardia, laryngospasm, muscle spasm, transient neuromuscular block can occur. So you can get this. And when you have to refer this patient for ICU support or ventilator support, if there is a respiratory, there is some indices If there is arterial oxygen tension less than 50 millimeter mercury on room air, or arterial CO carbon dioxide tension increases 50 millimeter mercury in the absence of metabolic acidosis. And there is also if FaO2 divided by FiO2 less than 250 millimeter of mercury, or pulmonary arterial alveolar oxygen gradient more than 350 millimeter of mercury. These are the indices for ventilatory support. If clinically, if you see respiratory rate is more than 35 breaths per minute, then also you have to think probably they may need ventilatory support. And mechanical indices, if vital capacity less than 15 ml per kg, or maximum inspiratory force less than minus 25 cm of water. So these are the indicators where patient may need ventilatory support, even intubation may be required. Now comes to the supportive therapy like antibiotic prophylaxis. If there is if you see there is indication of say infection, if there is features of infection, then you can give antibiotics, broad spectrum antibiotics. Risks of infection due to frequent and multiple interventions. There may be iatrogenic infection even can occur. Hydrocarbon aspiration. Injection of liquid concentrate of organophosphate, hydrocarbon solvent, aspiration causes chemical pneumonitis can occur. These cases are to be managed as a case of ARDS. Furosemide, it is recommended if pulmonary edema persists even after full atropinization, and then you can give furosemide to clear the lung edema. Diazepam is the first line therapy for seizure. If patient there is a repeated seizure, you can give diazepam. Now comes to the type 1 paralysis or acute paralysis. Seen during the initial cholinergic phase. This is when large number of both muscarinic and nicotinic receptors are occupied by acetylcholine, leading to persistent depolarization at the neuromuscular junction. Then there may be acute paralysis. Clinical features include muscle fasciculation, cramps, twitching, and weakness. At this stage, the patient may require ventilatory support due to weakness of the respiratory muscles, and because there may be respiratory depression and there may be the respiratory arrest. So in case of acute paralysis, if there is a features, then you can also give this patient the ventilatory support. You have to closely monitor. Now comes to the type 2 paralysis or intermediate syndrome. The intermediate syndrome is a distinct clinical entity that occurs after 24 hours to 96 hours, that is 1 to 4 days after the ingestion of OP compounds. Approximately 10 to 40% patients treated for acute poisoning develop this illness, about 40% patients. The onset of intermediate syndrome is often rapid with progression of muscle weakness. Onset from ocular muscles, the neck muscles, patient cannot even raise their head from the pillow, then proximal limbs and respiratory muscles, that is intercostal and diaphragm, over the course of 24 hours. So when you are seeing that this patient cannot open the eye, cannot raise his head from the pillow, there is even he can raise the upper limbs, and there is also difficulty in respiration, then you have to suspect. If it crosses 1 to 4 days, then you have to suspect patient may suffer from intermediate syndrome. Clinical manifestation of intermediate syndrome typically occurs 24 to 96 hours and affects conscious patient without fasciculation or other cholinergic signs. Marked weakness of the neck flexion, varying degrees of proximal limb weakness, manifested as weakness of shoulder abduction and hip flexion are the constant clinical features. Respiratory insufficiency is common and frequently draws medical attention to the onset of the syndrome. Other possible manifestations are involvement of muscle innervated by the motor cranial nerves and decreased deep tendon reflexes. Sensory impairment is not a clinical manifestation of intermediate syndrome. So, in this group of patients, you will see only the weakness, marked weakness of the ocular muscle, upper limb muscles, even the respiratory muscles. But there is no fasciculation or other cholinergic features, or there is no sensory impairment. Mechanism of intermediate syndrome is recognized as a disorder of neuromuscular junction. However, its exact underlying mechanism not clearly defined. And there may be there are proposed mechanism of intermediate syndromes are down regulation or desensitization of the postsynaptic acetylcholine receptors, prolonged acetylcholinesterase inhibition, failure of postsynaptic acetylcholine release, oxidative stress related myopathy, and there may be also muscle necrosis. These are the proposed mechanism. Exact mechanism actually not known. But most important is down regulation or desensitization of the postsynaptic acetylcholine receptors. It may be a cause. Now, what about the treatment? Main treatment is supportive, and there are no specific antidote available for this devastating syndrome. With supportive therapy, recovery from intermediate syndrome can occur 5 to 18 days after the onset of weakness. Regression of toxic signs among patients who survive intermediate syndrome followed a distinct pattern. Say, muscle for first resumed in cranial nerve innervated muscles, followed by respiratory muscles, then proximal muscles, then neck flexors. So in this way, the functional recovery can occur. Now comes to the type 3, that is organophosphate induced delayed polyneuropathy. It actually occurs 1 to 3 weeks after acute exposure, and you have seen intermediate syndrome occurs actually 1 to 4 days after the exposure of the poison, and here it is weeks, even it may be prolonged for even 4 weeks, months. So 1 to 3 weeks after, usually present with symptoms of cramping muscle pain followed by numbness and paresthesia in the distal, upper and lower limbs. Distal part mainly affected, cramping muscle pain, upper limbs and lower limbs. Can causes foot drop, wrist drop, muscle wasting, deformity such as clawing of the hands can occur. So a wrist drop can occur, foot drop can occur, muscle wasting and deformity can be seen, and clawing of the hands can occur. Physical examination, symmetrical flaccid weakness of the distal muscle, variable sensory loss, dominant hand affected more, say right hand, and tendon reflex are lost or reduced. Absent ankle reflex being a constant feature in this type 3 paralysis, that is organophosphate induced delayed polyneuropathy. So here you, that is nerves are mainly involved and distal part is mainly involved, upper limbs, lower limbs, foot drop, wrist drop, muscle wasting, deformity can occur. Variable sensory loss can even occur. What about the pathophysiology of this distal neuropathy, delayed distal neuropathy? Um, it neuropathy induced organophosphate compounds causes inhibition of carboxylesterase, that is neuropathy target esterase. Inhibition should be irreversible and significant. Degeneration of the distal region of the large long myelinated axons as the primary lesion, which progresses to Wallerian-like degeneration of affected fiber region. Inhibition of neuropathy targeted esterase is necessarily antecedent of organophosphate induced delayed neuropathy, but precise relationship has not been defined till now. So, physiological function of neuropathy target steroids is not known. Dichlorophos or and nerve agent are not associated with organophosphate induced delayed neuropathy. So these three types of neuropathy you can see in organophosphate poisoning, that is acute paralysis, that is intermediate syndrome, and delayed neuropathy can occur in this organophosphate poisoning. What about the treatment? Recovery from organophosphate induced delayed neuropathy is incomplete and may be limited to the hands and feet, and subsequent substantial functional recovery after 1 to 2 years may occur in younger patients. So it will take time, say even years together. Currently, no drug is appropriate for the treatment of organophosphate induced delayed neuropathy. So this is all about today's lecture. So if you